everybody. Welcome back to the show. Cameron English here with you as always, Director of Biosciences at the American Council on Science and Health. And I'm joined, like usual, by Dr. Chuck Dinerstein, our Director of Medicine. Chuck, how's it going?
Good. How are you today?
I am excited. I'm out here in California. It's not 111 degrees anymore. We're starting to get some fall weather, and that makes me a happy man.
Excellent. It's as it is here on Long Island. We have the fall has arrived. The leaves have not changed yet, but the weather is definitely telling me it's time to get a sweater.
You know, I get the impression that New Yorkers are just always a little spicier than most people. So do you notice a change in how people act when it gets cooler over there? Because it's very clear here. When it gets cooler, people just seem more relaxed. Is that the case over there in New York?
I guess it would be very tough to tell when the New Yorkers are more relaxed. What I have noticed is that there is a subgroup of New Yorkers that wear shorts all year round. It can be snowing, and they are wearing shorts. I've never understood how that can be. But
you got odd ducks over there, man. I don't get that either. Because you get like snow on the ground and stuff. All right, we'll stop. We'll stop psychoanalyzing New Yorkers and let's talk about our stories. So we've got two this week as always. Chuck, you're the author of both of these. They're both interesting in unique ways. So first we have Cocoa, Multivitamins, and Dementia, which is a look at a study that posits that these substances might actually, I don't know, if prevent the risk or decrease the risk of dementia. And then a far more controversial article, because people are either going to love you or hate you for writing this. Did COVID lockdowns work? So we'll dive into that in some detail. But tell us about this study you were writing about, Chuck, when it comes to dementia.
Well, the first study looks at a really simple dietary intervention. Can the use of cocoa, not chocolate bars, but cocoa, or a multivitamin every day stave off dementia? And the underlying biologic hypothesis was that both of these agents contain flavonoids. The multivitamins also contain other nutrients, and that perhaps supplementing people with these nutrients would make up for deficiencies that they have and improve their overall mentation. So what they wound up doing was a fairly large study. They looked at about 2,600 people over 3 years, some of them taking cocoa, some of them taking a multivitamin, both blinded to what they were taking. And they looked at the changes in their cognition during that period of time. And cognition really had to do with memory events as well as tasks that would allow you to abstract things or to multitask, that type of stuff. So what they found was that in the first 2 years, both the individuals taking cocoa and the individuals taking multivitamins showed an improvement in their scores from year 1 to year 2. The researchers were quick to point out that this didn't represent a real improvement in mentation as much as understanding how to do the test and taking the test over the phone, which was the way these tests were administered. So that the real results of the study were the results at year 3 when everybody was acclimated to the tests and saw how things went. And as it turns out, cocoa had no significant improvement in people's memory, which is really the area where the biggest gains or losses were to be noted. The multivitamin didn't make you less demented. It just prevented your dementia from getting worse. And that was what they concluded, was that for some reason that something within the multivitamin might have an effect on staving off further signs of dementia. So there is again some kind of bioplausible reasons for that, but there are a number of caveats to the study that we have to think about. First one is that they began with a population of about 36,000, and they wound up studying 2,600 volunteers. So it was a fairly selective group. More importantly, it was not a really reflective group of the people being considered. They were basically looking at people over age 65 that were obviously more at risk for developing dementia than 20 or 30-year-olds. But what they found was that it was a predominantly white population. Nearly 90% of the participants were white. More importantly, nearly 90% of the participants had attended or graduated from college, which is in distinction to the general population in the U.S., it's probably in the range of 40% on a good day. This population was a little bit overweight with a BMI of 27, but the general population of people over 65 tend to have a BMI that puts them in the 30 to 35% range. So they didn't match up that way. And last but not least, these people exercised a whole lot more than people in this age group. The average amount of time that somebody over 65 exercises during the course of the week is 2.5 hours. This group was doing 22 hours. So it wasn't a very representative sampling. So you have to take all of that into account when looking at the data.
So first question that comes to mind, how do you control for all of these variables that seem to shift radically depending on the population you're looking at? Because every study I read these days always has some sort of qualification along the lines of, this study's population doesn't perfectly match the general population in whatever country the study takes place in. Future research should try to replicate these results in different populations. But if everyone's saying that every time they publish a study, is anybody actually ever doing that study that they all say we need? So speak to that if you can.
Well, the answer is no, they're not. And so what you could hope for is that in a meta-analysis that people have done studies on multiple groups, and then you can kind of combine the data together to get a more sense of the general population. But it is a very interesting problem. I spoke this weekend with a friend who is deeply involved with research at Memorial Sloan Kettering in New York, and they cannot, despite a big effort to bring minorities into their research program, they just cannot recruit them. They're having a tough time recruiting general patients into research studies. And I think that they're just the tip of the iceberg. There's not a big inclination among people to want to be in a study when there are a lot of really good standard treatments available. And so in some ways, I guess we're a victim of our own success. So I think that it's going to be very tough to find studies anywhere that are going to be fully representative of the population. But I think that for the casual reader or the intense reader of these kind of studies, it's important to look at the population and see how representative it is of the people that you're seeking to understand or to treat.
So I get the impression from these sort of studies, whether they're actual clinical interventions or if they're epidemiological studies, when you're looking at something like a multivitamin or a supplement or just some common food or food ingredient, whatever effect these have, it's probably just going to be swamped by other variables that are more important to the disease in question. So I see, like with multivitamins, there's been research where they say, oh, there's a trend towards statistical significance for this multivitamin preventing depression, or B vitamins preventing depression, or something like that. But in the case of depression, we know that you need usually some kind of behavioral intervention with a licensed therapist, or you need a very powerful drug, or some combination of the two in order to treat that disorder. So what I'm getting at here is, are we looking at a situation like that with something like dementia?
I think so. I think that one of the problems is that all of these problems are multidimensional and biologic systems are very dynamic. Science has forever and a day been based on isolating variables and seeing how they respond. And in many areas outside of biology, chemistry and physics in particular, that has proven to be a very useful approach. But in biologic systems where all the various parts are interacting, isolating a variable at a time and looking at it doesn't give you at all a good idea of what goes on. That's why all of these studies that look at isolated nutrients will show one thing, and then when you put the nutrients back into the pile, they don't show anywhere near the effectiveness that they might have shown in the study. To your other point about how they equivocate, I pulled the quote at the end of the study, and there's a lot of equivocation in there. They wind up saying that this is the first study to suggest that the daily use of a safe, readily accessible, and relatively low-cost multivitamin supplement has the potential to improve or protect cognition. So we got suggest and potential. Certainly not great firm evidence to base treatment on. On the other hand, the fact that we're talking about a Centrum Silver that's going to cost you, a nickel a day, most people are going to say, what the heck? Can't hurt, doesn't cost me a lot. Why not do
it? That's sort of what that summary sounds like. That's the academic equivalent of, what the hell, just take it. And if nothing happens, big deal. But you can't say that in a refereed article, but they come close. Am I right on that? That's what it sounds like to me.
That's exactly where they're going with it.
Okay.
We can't prove for sure that it's helping, but it certainly doesn't hurt. Nobody got sick from the vitamin. So why not do it? The other interesting thing when I thought was interesting about it was the funding for the study came from the Mars Corporation. They're the candy people. They're the ones that paid for the cocoa. And the Centrum Silver people donated all the vitamins. And in the commentary, the authors made a point of pointing out that they had received the vitamins from Centrum and that they had nothing to do with the study, but didn't make anywhere near the effort to say the same thing about the Mars company, which had a negative result. I mean, if you're going to talk about conflicts of interest or the funding sources, it seems that whether they're positive or negative, you should mention them rather than simply mention them when you think that the specter of conflict of interest might be raised.
What was interesting about that, and I didn't know this until I read this in your article, but Pfizer owns the Centrum brand, right? So
yeah.
The study's funded in part by Pfizer, and this is just an abstract question. I didn't see any evidence of this, but the people who I think of as being skeptical of corporate or industry-funded research are the same people who, without a second thought, would take a COVID shot, or take a COVID booster, which, of course, many of which are also made by Pfizer. So can you talk about why people seem selective in their concern about industry funding? Is it just the topic that happens to be under discussion at a given point, or what's going on, do you think?
I think it has to do with the industry at hand, because I think that you see it all over the place. You see it with the with Pfizer and the COVID vaccinations, for sure. Those people that have a high trust in government are going down and plunking themselves down and getting themselves the Pfizer shot. They may have very different views of things when you ask them about whether Big Pharma is gouging us on prices. On the other hand, for the same vaccination, you find a lot of people that are very supportive of former President Trump, who has to be really given credit for Operation Warp Speed and bringing the vaccines to the public, refuse to have them at all. And I think it really gets down to who you distrust on any particular day, how you come down on one issue or another. There's no logic necessary to our feelings in that regard.
Well, that's a very beautiful lead into our next story, Chuck, which is, did COVID lockdowns work? And I think that really gets to the heart of what people are going to think of this story. So introduce us. What are you talking about here?
Well, So we've entered the phase in the pandemic where the shame and blame portions of the review are underway. And the study here looked at whether the lockdowns across 80 different countries made a difference in outcome. So the first problem of all with this is there's no control group. And so all of the studies that they looked at model the potential deaths if the lockdowns had not taken place. Now there are some examples where we can see where lockdowns make a big difference. The biggest example that they gave, of course, would be China, which had a zero COVID policy. And when they say they locked you down, they locked you in your apartment and put guards at the apartment. And with that approach, they had something on the order of 1.6 deaths per 100,000. In the U.S., where we had our own version of lockdowns, we had 318. So a big difference just based on how those lockdowns went into place. What I found interesting in the study was, again, the dynamics of two portions of it. First was the fact that what they found was that early lockdown resulted in sparing more lives, which makes some kind of logical sense, because if you think about it in exponentially growing infection, the earlier you get in to treat it, the lower the exponential numbers are going to be. So that doesn't seem particularly surprising. What they did find was that the only place where lockdowns overall were effective were in small groups and large groups. Small groups would be families, where if you could quarantine people within families, that makes a certain amount of sense. That's tough to do. There's a lot of good data that suggests that the population density within the apartment building or the apartment had a bigger effect on things than anything else. And then large groups, where we think about these events they've described as super spreaders. So that there's that general component of what they found. The dynamic part has to do with the fact that the public health people didn't have a very good handle on how infectious this disease was to begin with. If you remember back in the U.S., there was 2-3 cases, and all of a sudden you have all these reports out of New York as more and more people in the New York nursing homes were getting sick and dying. And at that point in time, the infectivity, the R naught of COVID, was estimated to be up in the 4 or 5 range, up there with measles, which is a fairly contagious disease. What we found out over time, as the disease spread to the less frail, was that its infectivity is closer to that of the flu. So when you talk about early lockdowns, there's an argument to be made, because when you look at the data in New York, you say, gee, there's a horrible disease coming here. We have to lock everybody down. But the problem with doing that is the later data suggests that may have been crying wolf. And that's something to being avoided. The other piece that runs through here that really makes the biggest difference, and that is hard to put into articles and studies, is that the infection was also modified by our behavior. Two examples to point to. Weeks before they decided to lock down Florida, all the people who were in Florida that were at risk had locked themselves down. We know that from the cell phone data, that 2 or 3 weeks before the state even suggested people shelter in place, the people over 65 had already started sheltering themselves in place. The other group that I thought was interesting was in Peru, where they had a very stringent lockdown, but because of the way the economy works, which is a very kind of large, informal workforce, people continued to go to work. So it had no effect. So that our behavior and our culture interact interacted with COVID, interacts with any disease, and alters the outcome. And predicting human behavior is really tough.
So much to talk about here. First thing that comes to mind, though, and I just want to get your response to this, because my perception, especially early in 2020, once it was clear that we were going to have mask mandates and we were going to have lockdowns and so forth, there was this presumption among a lot of reporters and a lot of people in public health that we're going to do these things until somebody illustrates that they're not helpful or that they're even harmful. And I found that kind of irritating because that's typically not how we do science, right? And I understand that this is an emergency situation. Maybe you don't have the best data. Maybe you are operating with a higher degree of uncertainty. But there was this sort of attitude, like if you came forward and you said, well, I have to pay my mortgage. I have 3 kids and a wife, and they need to eat. I can't just sit here and watch Tiger King for 2 weeks or for 4 months or whatever. And your $1,200 check is not gonna, it's not gonna cut the mustard, so to speak. So I'm wondering if you can speak to that. Maybe you agree or disagree. I'm not sure, but give me your thoughts.
The key point here is that public health policy, mandates, whatever you wish to call them, may be science-based, but they are not scientific decisions. You have to understand that that's really, to my mind, the key across the whole spectrum here. What you describe is weighing a epidemiologic risk versus an economic risk. And you can weight those in any direction that you wish. For public health officials and for people that felt at risk, every life is precious, and therefore the shift should be towards saving every possible life. To individuals that did not feel at the same risk, and then in fact, as it turns out, were not at necessarily as great a risk as the initial population, disruption of their day-to-day lives was a more weighty factor, and they tilted themselves in the other direction. So what I came away with was that these are kind of ethical, subjective choices, and that when we use the refrain "follow the science," it belittles the role of science, and it makes public health decisions far less transparent and definitely less accountable. And has not been a good communication overall.
Yeah, I think that's the thrust of it, is that every time there was a decision made, that was the science at that given moment, and when that flipped, that was the science. And I think people just got fed up with that sort of rhetoric. And we've talked about this before. If they would have come out like Francis Collins and Tony Fauci, if these folks would have come out and they said, here's our best understanding of how this works. We are uncertain about this, but, we're making the best decision we can. Let's team up and let's get together. And then maybe there could have been some concessions in there, like, we understand this is hard for you and we're sorry. And here's what we're going to do to try to mitigate these pains that you're feeling. But there really wasn't a lot of that. I mean, later on there was, well, we'll just print a bunch of money.
Right.
So there you go. Yeah. So talk about that. It seems that the approach to these policies could have been handled with a little more delicacy.
Well, certainly more nuance. And I think that that's the problem, is that the public health mandates were not well focused, and that they were not well focused for a number of reasons, among which it's very difficult to say, you people that are 25 to 40 can go to work, you people that are 40 to 50 that have this disease have to stay home, you people over 65 have to stay home. People are not going to be able to wander through all the nuances of it. And so in a lot of ways, public health mandates are all or none. And it's applying a blunt instrument to a problem that needs a little bit more surgical precision and nuance. And I think that's a problem that is always with us. The For me, the big take-home message was the difficulty in disentangling our facts from our beliefs, and that's just a very human foible. And I thought that it would be worthwhile for the public officials and the opponents on either side of these discussions to be a little bit more humble in the face of our human behavior. And then the quote that I began the article with, which I will put back in here because I think it really captures the whole problem with talking about COVID and what we did is the words of Yogi Berra, who knew he was a great epidemiologist. In theory, there's no difference between theory and practice. In practice, there is. And that really gets to the essence of why follow the science as a refrain was not useful and why there's such acrimony, I think, over the decisions we made.
So let's talk a little bit about how you go about analyzing outcomes related to lockdowns. And of course, I think most people listening to this are at least familiar with the infamous or famous, however you want to describe it, Johns Hopkins review of the lockdowns. And that pretty clearly showed, at least according to the authors, that the lockdowns weren't worth the costs. But I've heard multiple people point out, and interestingly, I've heard this from people who I know were critical of the lockdowns, like people like economists who understand how these modeling techniques work, is they would say, well, you can just, you turn one dial down a little bit and then you turn another one up a little bit, and then that's going to influence your results. And you might do that without even knowing that you're consciously doing it. Most researchers don't go, I want to get result A, therefore I'm going to adjust variable B 18%, and then I'm going to get what I want, right? It's cognitively, It's more nuanced than that. So what are your thoughts on how this research is done?
Well, I think that you're exactly correct, and that you see it very nicely when economists try to put a value on a given life. And that's what I was trying to get at earlier. Those people that believe that every life is precious will place the highest possible value on the lives at risk here. Those people that feel the economy needs to be weighted more will either lower the cost of those lives lost, or somehow find a way to increase or inflate the cost of the lockdown to the economy. And both sides do it. I don't know that it's necessarily intentional. It may just be the way that they view things. When you think about the economy and the losses into the economy, at some point you can factor in the mental distress that this causes and assign some value to mental distress for not being able to go to work. And you can argue that that's not an unreasonable thing, because we have some data that suggests that domestic violence did increase during the lockdowns. Being locked up with your spouse can be stressful. So I think you're right. It's not only how you dial in the estimates, but the number of variables that you put into the model that make a difference, so that we can always add another variable or tweak this number and get a result that we're looking for.
Yeah, it's interesting to just look at all of the considerations that go into this. Is there anything else people should take away from this? For me, the thing that's most important is that we need, and this sounds cliche to say this, but we need open dialogue, and we need people who understand the underlying science and epidemiology arguing with each other about this stuff. And I think I was trying to get at that with my first question, but people like a new policy would come out or a new study would come out, and you simply were not allowed in respectable circles to critique it with any degree of seriousness. You could see, maybe the effect was slightly lower than they thought it was, but to come out and say the methodology of this study was just bad and we shouldn't base policy on this. You weren't allowed to do that. And I think that was the problem. It wasn't any one outcome. It was just that this is what we're going to do. You toe the line or you're a shill for the oil industry.
Right. Okay.
So go, what are your thoughts?
No disagreement there. I think that the big public health failing was saying we don't know. This is our best guess. And after we kicked it around, we think this is the best approach to take. Now, again, when you apply that thinking to policy, there may be some disruption in that. When you're starting to tell everybody that they have to stay home, it may be that you don't want a lot of wiggle room in that statement. But long term, that's more harmful to public policy and discourse than it's not. And I think the other take home that I have at the moment is that we continue the same behavior with this shame and blame and continuing to accuse one side or the other of poor intent in their feelings, rather than saying we had an honest disagreement and how can we move forward and compromise. We just don't do it.
That's no fun, Chuck. There's got to be a bad guy, and the bad guy's got to be the guy that votes differently than I do.
Well, by definition.
Yeah, it's troubling. There were a few examples that really creeped me out. The biggest I can think of was Jimmy Kimmel on his show talking about hospitals refusing treatment to people who did not get a vaccine. So for example, he said in one of his monologues, "Oh, guy that got both doses of his Pfizer vaccine, you're having a heart attack, come right in. We'll take good care of you. Guy that gobbled horse goo," meaning ivermectin, "rest in peace, Wheezy." So it was like, I get why that joke is kind of funny, but it's also just so ghastly and ghoulish, right? Because the whole point of getting people vaccinated is to say, this will keep you out of the hospital. This will keep you out of the morgue. As you said earlier, we want to preserve life because life is precious. But I didn't get that impression from people, right? The impression was you do what we want or you die.
Right. And a lot of the people that had these opinions weren't actually involved in providing care. While I can understand that sentiment about why are you darkening my door, you could have had the vaccine and prevented this visit, I don't know anybody that would refuse care. I just don't. I've taken care of a lot of gunshot wounds in my youth, and we didn't really wonder who was discharging the weapon and why at the time of taking care of them. And then there's something to be said about the fact that when you're making decisions that will lead to people dying, I think you kind of tighten up for a moment before you make those pronouncements. It's very easy to make pronouncements on Twitter about we should have done this or we should have done that when your decisions actually don't have any impact.
That's a good point as we wrap up here. I imagine, and I'm sure you can confirm this, that if you were, as a surgeon, if you were to say, I'm not operating on anyone who's involved in a gangland shooting, right? If there's bad guys shooting at each other, you reap what you sow. Too bad. I imagine that would be a great way to get your medical license revoked, right?
You would certainly be explaining to the hospital why it was that you took that position. I mean, we can take a better example than that. I mean, I did my surgical training in early surgical years during the AIDS epidemic, and one of the things I was doing as a vascular surgeon was putting in access so that these patients could have dialysis. And most of the patients at this point in their care, if they needed to be on dialysis, were not going to survive. But we were taking them up to the operating room. We were exposing the anesthesiologist, the OR staff, and ourselves to blood spatter because that was an unfortunate unintended plan that comes with any kind of rebuilding of arteries. And we just did it. We didn't get into a long ethical conversation amongst ourselves about, how they had gotten AIDS and whether it was a good thing or a bad thing or anything else. So I come from a tradition where the decisions that I made, at least at work, actually had life and death consequences. So I've learned to be a little bit more humble. Not a lot, a little bit more humble in talking about them and choosing which direction to go. And I just don't think that most of the talking heads on television or anywhere else feel that way. And that makes a difference.
I think that's something everybody can agree with. Before we go, I've been meaning to plan this, but I think we should do an episode where you talk about some of these anecdotes from your days as a surgeon. Like, people come in with gunshots, your first time in the OR, just crazy stuff that happens, not in reference to what we're talking about in the news, but I think that would be interesting just to do that. Maybe we'll have to set that up in the near future. Enough. All right. Well, we're going to leave it there. You guys, thank you for joining us as always. If you want to get these stories that we're talking about, you just go to our website, acsh.org. Click the subscribe tab up there at the top, punch in your email. We will send you these stories 3 times a week. And at the end of the week, we look at it, at what you're reading, and then we're going to talk about those ones. So if you want to be a little more informed and more prepared for these discussions, sign up for our newsletter. And then also we're on Twitter. We're on all the social media. It's on Twitter. It's at ACSH.org. And Facebook, LinkedIn, American Council on Science and Health. You'll find us if you want to find us. Thank you so much, and we will see you next week.